Ladies and gentlemen, please welcome to the stage the Chair of NHS Confederation, Stephen Dorrell.
Good morning, ladies and gentlemen. Welcome to day 2 of Confed18. I hope you had a good evening in Manchester and that you've recovered from your good evening in Manchester. We should begin this morning on a sombre note. No one who was present on the first day of the Confed conference last year will forget that was the day of the fire at Grenfell Tower. And in common with the rest of the nation, we shall be observing 1 minute's silence at 12 o'clock today as a mark of respect for those who died there, and within the health service family to remember, I think, those who were referred to yesterday by Simon Stevens for their huge contribution, dramatic contribution to the supporting the community around Grenfell Tower. So we shall be marking our respect for all of that at 12 o'clock today. Before then, however, we have a full morning's conference agenda. I have to tell you that it's been changed slightly. Those who follow these things on the digital media will know. Those who rely on the printed conference agenda will not yet know. But the Secretary of State's diary has been changed again. So he will be on the stage this afternoon at 3:15. And this morning, I'm about to introduce the Chief Exec of the Confed. He will be followed by Ian Cummings and followed by the big debate chaired by John Humphrys. So my role this morning is extremely simple. It is to introduce someone who spent most of yesterday actually on this stage, so it's faintly ridiculous for me to be introducing Niall Dickson to you. But it's a huge personal pleasure to be able to do so, because I think that in the now roughly 18 months since Niall took up the post as chair of the Confed, as chief exec of the Confed, I should say, he has established his own personal reputation as a thoughtful, authoritative and respected contributor to the national debate on health, and has put the Confed stage centre in contributing to that debate. So, ladies and gentlemen, please welcome Niall Dickson, the Chief Executive of the NHS Confederation.
Well, a very good morning. 15 minutes walk from this hall is the Manchester Arena. And it's just over a year ago, as Ariana Grande finished her encore, that a suicide bomber set off a blast that killed 23 mainly young people, and 139 were wounded, some with terrible injuries. The response, and again reflecting the comments Stephen made about Grenfell, from NHS staff was not only tireless, selfless and committed, it was effective, the result of very careful planning, good and trusting relationships. As one medic put it, staff from almost every imaginable background, race and religion came together and put their all into caring for those wounded. And it is right, at times of adversity and national trauma in Manchester, as in Grenfell exactly a year ago, when the spotlight is shining on this service, we see something special. And even today, after 70 amazing years, it is a more diverse service than ever, and I would argue one with even greater potential. And that's why later this afternoon, it's right that we celebrate together what's been achieved by this extraordinary and powerful institution, which has captured the hearts of the British people. And I hope we will renew our vows as well to strengthen and protect it in the years ahead. In my remarks this morning, I want to suggest we're at a moment when key decisions need to be made about what we're willing to invest in our health and care system. I will argue that we need to make a compact with the British people about what they will receive in return for a longer-term settlement, and that if we are to deliver our side of that bargain, we will need to act locally and nationally to create a framework that will facilitate radical transformation and build the workforce that will be required. I think this conference has underlined this shared realization that we have reached a seminal moment. It won't be the first time that this service has found itself at such a crossroads. In 1948, obviously, in the early 70s and the early 90s, the service faced existential challenges, as it did at the start of the new millennium. In some ways, the challenges today are greater, and the economic and political terrain is more uncertain. But as a society, I hope we have at least begun to recognize that we are at one of those critical junctions. When it comes to investment, at the Confederation, we've been calling in public and working behind the scenes for three things. One, a significant commitment. The minimum we now believe is necessary, based on the IFS Health Foundation study, is 4% real terms growth for both health and social care every year for the next 15 years. I'm not saying, incidentally, that the politicians will be able to make that promise for 15 years, but we do want a longer-term commitment. Two, a bringing together of health and social care funding. We simply cannot allow social care to disintegrate any further. And three, a longer-term settlement to provide stability, the stability that we need to plan and transform. And we are clear the system needs a reset. There is already a substantial gap, and it's a growing one, between what we can deliver and what is needed. Just to return to the constitutional standards on elective care, we would need an additional 600,000 admissions just to clear the backlog. That's why the IFS Health Foundation report recommends further additional funding in the early years to take us back over a period of time to the key standards we were achieving a few years ago. Now, too often it has taken tragedy to trigger change. If you think of Hillsborough, Dunblane, Grenfell, and in health, Bristol, Midstaffs, Morecambe Bay. But for us, there is now a window of opportunity before tragedy strikes, to act before the service cracks under the strain and, frankly, is unable to provide safe care. The good news is that I think we've begun to see a switch in government thinking. And I think we should give the Secretary of State in particular credit for fighting hard to convince a sceptical Treasury, as well as colleagues on the front and back benches, that a different approach is needed. Indeed, in each of the areas where we've been pressing, we have seen some signs of movement. But as yet, I have to say it's not clear, I'm not sure if it will be clear by the end of this afternoon either, of what is required to make these changes. The experience of the first decade of this century, however, shows clearly that investment can deliver results. But it needs to be focused and targeted, and we need a shared understanding of what can be done and over what period. In short, in England at least, we need a new plan for health and care, developed, created, and agreed with the service and the wider public. Our immediate concern is that a quickly devised, centrally imposed plan will fail to address the enormity of the challenge or the need to secure widespread support. We had some reassurances in this yesterday from Simon, but the promised engagement really does need to be real. We need a new compact or agreement between government, NHS and public. And for the avoidance of doubt, we're talking about months, not years, for this engagement process. But I believe the service is willing to have its feet held to the fire in exchange for adequate resources and a coherent plan. But any new strings attached to this money should be the result of a conversation. It must be realistic and rooted in the realities of a 20th century service and the demands that that brings. Now, I'm conscious that much of what I'm now saying applies to England rather than to other parts of the UK. The challenges are, unsurprisingly perhaps, remarkably similar. But in Northern Ireland, they already have Health and Wellbeing 2026, delivering together, and in Wales, they have Revolution from Within Transforming Health and Care in Wales. These are clear blueprints with some degree of political and service consensus about the way forward. And let me just in passing pay tribute to the Northern Ireland and Welsh Confederations, both of whom are part of the NHS Confederation group, who've played such a vital role in convening different parts of their system and in providing a distinctive voice for the service. So what might be the issues such a plan for England would need to address? It has to begin with an admission. Even with additional investment, the system is unsustainable without fundamental reform. We heard that unequivocally yesterday from Ian Dalton, and the IFS Foundation report estimated that in 10 years' time, if we go on as we are, we will need 50% more acute beds. And obviously that is not credible. And so in a sense, the underlying question is simple. How do we create a sustainable system which effectively manages growing demand? The success of the next 10 to 15 years will depend on our ability to tackle this. And it's against that question we should perhaps judge each element. First, there is the vexed issue of the relationship between what is national and what is local. Now, the latest moves to reform the regulatory architecture articulated by Simon and Ian are really welcome. The prospects of a genuinely coordinated approach between NHSI and NHSE, and a much greater emphasis on support and improvement, and a commitment to break down traditional boundaries between different parts of the system. The intention is good, but as one of you pointed out to me last night, we've seen good intentions before, and this in part is about cultural and behavioural change. And it will need to go further. The centre should be about agreeing strategic direction, setting objectives, creating or helping to create the right environment, and freeing good leaders to deliver great care. Secondly, and related to this, I think we're all agreed that the current payments and incentive system is simply not fit for purpose. One set of complicated rules arrived to replace another, with more and more organisations ending up in deficit, having tried to manage impossible targets. What's needed is a set of performance management arrangements and financial incentives which support system working and encourage investment in new models of care. Now, to be fair, green shoots are appearing, and we saw plenty of examples of that in Simon's film yesterday. But many of these have been delivered in spite, not because of, the current arrangements. And we need to roll out what works faster and more systematically than we have managed hitherto. Third, we need legislative change. Much of what is being attempted now amounts to workarounds and local fixes, and all the more commendable for that. But as a taxpayer or a patient or a service user of a nationally funded service, I want to understand who is responsible for what and how I can hold them to account. Clarity and simplicity are needed, with organisational forms that support rather than hinder integrated delivery. Fourth, we must finally deal with the challenge of mental health and social care. We've made some progress on mental health, and it's to the credit of leaders with and beyond the NHS that we have a commitment to, and some progress on, moves towards parity of esteem. It will be critical in any NHS implementation plan that clear milestones are set, and that both in terms of funding and outcomes, the current momentum around mental health reform is maintained. On social care, I have to say we seem to be at ground zero. Again, both the Health Secretary and the Prime Minister appear committed. He now even has social care in his job title. But we've spent more than 20 years lamenting this problem, and we've spent more than 20 years failing to act. The promised Green Paper has been delayed at least 3 times. We can't go on like this. The levels of unmet need are nothing short of a disgrace, and they result in unnecessary health costs and unnecessary suffering. At the Confederation, we set out 10 areas where action is needed, and our members have consistently argued that unless we tackle this, the health service itself will continue to struggle. Like mental health, our ambition for social care should be parity of esteem. Fifth, we failed to invest at the speed or with the urgency required in new models of care in the community. It is really shocking that over the past 8 years, spending on primary care in England has actually fallen in real terms. Indeed, from the mid-90s, the number of hospital doctors has increased by 72%, whereas in the same period, the number of GPs fell by 5%. Now, this is not about attacking the acute sector, but unless we invest in and reform the services that surround our hospitals, the whole system will fail. That means getting to grips with the division between social, primary and community care, bringing teams and budgets together, using data to segment the population and target interventions, and making sure that care and support is offered at the right place at the right time. Already we can see what's possible with primary care home and similar models which create an integrated workforce, close partnerships and shared budgets with a joint commitment to health outcomes and for a defined population. But again, the pace of change needs to accelerate. Incidentally, with NHS providers, we've set up a new network to provide a stronger, louder voice for community services. We believe that voice will be vital to help secure investment and drive reform that is needed in that sector. 6, we need to have an open and honest conversation about the future of commissioning in England. Our view, informed by NHS clinical commissioners, who are another part of the Confederation, is that we need to see the development of a form of strategic commissioning, that continuing involvement and leadership from the clinical community is vital, and that commissioning needs to come together with local government and be on a larger scale. Commissioning has, I'm sure it's shared in this audience, has had its critics, indeed since the purchaser-provider split was created in 1990. But we also believe it would be a mistake to return to a closed system of allocations without significant local accountability for provision. And we need a new national settlement with local government that shapes how local services are commissioned. It would, in our view, be a mistake if we allowed the emergence of large NHS monopolies and the exclusion of social enterprises and other community interest operations, exclusion of local government, third sector providers, and the independent sector, all of whom can add a different dimension, foster innovation, and sometimes, yes, put some grit into the oyster. Indeed, drawing on independent sector capacity back in the 2000s was a big part of helping to cut long waiting lists. And we need to think through how the non-statutory provider sector can be given a clear role in integrated care systems, a point that was made clearly this week by the Commons Health and Social Care Committee. And last but not least, certainly not least, we need national and local strategies to deal with the workforce crisis. We'll have more of that in a moment with Ian Cumming. Lack of qualified clinical staff is likely to be the biggest impediment to us making effective use of additional funds. As the draft workforce strategy makes clear, we need to act quickly. The recent investment in pay was vital in making us more competitive in a tough labour market, which will only become tougher as we leave the EU. The Confederation, through NHS employers, is proud of the deal that we agreed with the unions, and I want to say a big thanks to the team for achieving that. Securing extra staff will take time, but we also believe there are immediate steps to be taken. The government must act urgently to reform the present migration system, preferably by tomorrow morning, if that's at all possible. 1,800 rejected work permits for much-needed doctors was totally unnecessary. It sends the wrong signal and adds strain and cost to teams operating under enormous pressure. The inflexibility of the current apprenticeship levy prevents the NHS funding much-needed additional entry routes into nursing and indeed other roles. And a reinstatement of the professional development training funds, which were drastically reduced 3 years ago, have had a really bad effect on morale. They are all signs of how the system values our people. The IFSH Health Foundation report estimated that over the next 15 years, the English NHS is likely to require 64,000 extra hospital doctors and 171,000 extra nurses, not to mention the additional community staff I mentioned earlier. We need a well thought through plan of how we're going to train, recruit and retain them, and to develop new roles to meet the changing needs of the patient population. In addition to all this, though, there's much that we can do ourselves as a sector to meet the coming challenges. And it's right that government, politicians and the public expect us not simply to appear as an apparition holding a begging bowl. So what more will we need to do as a sector? Well, first, just staying on this workforce, the plug in workforce is as important as the tap. And in spite of great progress in many organisations, there remain unjustified variations in retention rates. Overall, the NHS across England is a good employer, with the 2017 staff survey showing a relatively high level of staff engagement. But the figures also show that more needs to be done on staff satisfaction, on flexible working, sickness rates, bullying behaviour, discrimination, and the use of agencies. Again, big progress in almost all those areas, but an awful lot more to do. And I wonder whether we're also sensitive enough to the mood of the professions who deliver the care. The Bawa Garba case has rocked the medical profession and dented confidence among doctors and other professionals. In all our efforts to reform and adapt the NHS, we need to engage and empower clinical staff in shaping future services, giving them the tools of data and quality improvement to drive change. For without their active support, the reforms will certainly founder. NHS Employers, incidentally, has a retention checklist which covers issues such as using data to know your staff, flexible working, flexible retirement options, talent management and development, if you're interested in following that up. Some of you, of course, face more difficult challenges than others, from rurality, which is a huge problem in terms of recruitment, to recruiting into less popular specialties. But this has to be a key component of our workforce strategy, retention, and it has to be led from the board. There's also more we can do on race and equality. We celebrated at the beginning of this conference the achievements of the Windrush generation, but we need to do more to create opportunities for all our staff. And within the Confederation Group, we'll be working with NHS England and with members on taking forward the workforce race equality standard and more generally making the case that developing all our staff is not just the right thing to do, it's what actually makes really good business sense. Secondly, as a sector, I'm sure we're going to be expected to wage war on unwarranted variation. We'll never achieve uniformity, of course, but with the expansion of data and a better understanding of outcomes, there are now opportunities to do things better and to do better things. There are various programs for combating clinical variation, and as the recent Carter report recommended, extending programs such as GIRF, the Getting It Right First Time, to community-based services is another obvious thing to do. The same relentless attention needs to go on service configuration and administrative support. The variation on estates costs per area covered varies from £105 to £970, and it's a similar story on back office and procurement. And perhaps the greatest prize will be creating patient and user pathways that are centred around the patient and the user, again providing the right care at the right time. And thirdly, I think we do have to try and escape from the silo working which has blighted us for the last 70 years. There's always been, I think, a tendency in our sector to believe that wherever we're sitting is the centre of the health and care universe. It's fostered a mentality which sometimes fails to show how interdependent each part of the system is upon the other. Now, this is really changing now. I think it's one of the most exciting things. But we still have to overcome misunderstandings and fissures between primary and secondary care, between primary and community, between health and social, between mental and physical, between statutory and non-statutorily delivered services. None of those divisions, incidentally, make the slightest sense to anyone who actually uses our services. And this is where the moves towards integrated care systems can make such a difference in changing perceptions and breaking down barriers. Within the Confederation Group, We bring together the different parts of the NHS family, and our ambition is to do everything we can to support this coming together of different parts of the system. In the autumn, we'll be launching our regional support service, which will work with members, SDPs, and integrated care systems across England. We hope this small team will support joint working and provide a closer link between the Confederation nationally and our members, enabling us to represent your views more effectively, spread good practice, and help drive local agendas. They will seek to work across the patch with the NHS, providers and commissioners, local government and the independent sector, as well as the voluntary sector. Fourthly, we will need to embrace innovation and change more comprehensively and at a faster pace. We're not short of projects and good ideas that break new ground. We actually have been less good at spreading them. I hope you've found some over the past couple of days that you can take back with you to your organisations and systems. And I want to pay tribute here to another part of the Confederation family, the academic health science networks, whose licences have just been renewed for another 5 years. As Ian Dodge of NHS England said at the time, this is the national network which can help us to destroy the not invented here syndrome. And related to this, is it not time for us to think more about our relationship with all our suppliers? Eric Nordkamp yesterday cited the Life Sciences Strategy, which calls for a much more engaged and forward-looking relationship between industry and the NHS, and makes the critical point that many of the opportunities ahead are uniquely available to the NHS and couldn't be realised in many insurance-based healthcare systems. The strategy points to the clear advantages for more interaction between industry and the NHS in the evaluation of products, how the UK and patients and clinicians would benefit from innovative product use in clinical trials, and as Eric said, this is not just about academic centres of excellence or even just about hospitals. Now, I'm enormously proud of one aspect of the talk I've just given you. I've managed to get through all this without mentioning the word Brexit. Now, it's a phenomenon that hangs over so much of our national life, and it's contributing to so much uncertainty. As I hope you know, we set up the Brexit Health Alliance last year, bringing together the NHS, health professionals, pharma and devices industry, research institutions, patient groups, to campaign for the best possible deal for UK patients. We have had traction with and support from ministers and officials in the UK government, and indeed with negotiators in UK negotiators in Brussels. And I hope and believe we have kept health on the agenda throughout, even though it's not an EU competence, which is one of the fears. The Confederation's European office has also succeeded in mobilising European organisations to put pressure on the Commission and raise awareness of the risks, not just to British patients, but to European ones as well, if we get a poor deal. Yesterday, we launched our latest campaign on public health. This must surely be one area where we recognise that maximum collaboration is in all our interests. Diseases do not recognise borders. We're working hard to represent your interests and views, and not just on Brexit. After the long campaign to highlight social care, there was some more money. And the Health Secretary, as I mentioned now, has social care added to his job title. After creating a coalition of organisations, we wrote to the Prime Minister about the need for a long-term funding settlement, and she has now promised a multi-year funding plan. With the seminal report on funding, we have helped to trigger a national debate. But none of this would have been possible without the insights and support of you, our members. The Confed Group is a single charity, but within it is a wide coalition. It reaches into every healthcare organisation in England, Wales and Northern Ireland, through NHS employers, the Welsh and Northern Ireland Confederations, NHS clinical commissioners, the new community network I mentioned, NHS partners and the mental health network, as well as the individual direct members of the group. We believe there's never been such an important time for the diverse organisations that make up health and care to come together locally and nationally, to find common ground and to help to shape a different future. And we believe we can play a part in that, and that our new regional team, our networks and our national offices can convene, provide support and act as a conduit between local reality and national policy. And if you're not a member, you're paying too much to be at this conference, first of all, so please join us. Thanks very much. Okay. Okay, do you go on?
Thank you very much, Neil. That was great, and we now need to move on, but it was great. Thank you for crystallising those thoughts.
Thank you very much. Good stuff. Okay, let's move on. I mentioned that we were going to talk about workforce, and yesterday in a poll, this audience, workforce was the clear runner-up on the issues of the moment. We are, above all, a people business. How we use, deploy, motivate, inspire, and train our staff determines how well we're due. As a sector, we have to concede that we've not planned well, we've not trained enough, and we're ill-prepared for a future which will require many more staff. It's a great pleasure now to introduce the man who's going to solve all our problems and who deserves great credit for pushing to get a long overdue strategy underway. Please welcome the Chief Executive of Health Education England, Ian Cumming.
Thanks very much indeed, Neil, and thank you for the invitation to address you today on this day in which we remember the tragedy from 12 months ago of Grenfell Tower. I wanted to talk to you today about the draft workforce strategy that was published last December and some of the consequences of what we've received in feedback to that draft strategy and how we take that forward as we start to produce the final workforce strategy later on this year. So, facing the facts, shaping the future, I want to talk today about facts and I want to talk about the future. As you will see from the slide, the consultation response to this document was simply overwhelming. We had responses from every profession, we had responses from every part of the country, over 3,000 individual and organisational responses containing 9,000 ideas, thoughts and comments. We received 200 formal written responses from organisations in this country and over 500,000 words of written feedback. That completely blew me away, but I think it reinforces what we've heard time after time, that workforce is one of the most important factors facing our NHS. 6 key themes came out in the consultation. More people need to be trained. We should aim for an oversupply, not the best guess of where we think we might need to be. Let's train for more than we think we need. We need to become an employer of choice. We need to be what was described as a modern model employer. We need to invest more in our existing workforce. We need to better align service planning, workforce planning, and financial planning. And we need to take a multidisciplinary and multi-sector approach to the workforce. But there were some aspects that were less positive. And one interesting point is that we did see some divergence from what we have had reported back from the NHS staff survey. So only 63% of respondents to our consultation would recommend a career in healthcare to friends and family. Only 69% of respondents to our consultation would recommend to friends and family that they pursue their own profession as a career. We need to address that. We need to understand the reasons behind that. Now, we often find ourselves talking about the 1.4 million people who work for the NHS. Just for a moment, let's add on to that the 1.5 million people who work in social care. Let's add on to that the 3 million volunteers across health and social care. Let's add on to that the 5.5 million people who are unpaid carers in this country and the 170,000 people who are in education and training to become healthcare professionals. That gives a total of over 11 million people actually involved one way or another in delivering health and care in this country. About 20% of the entire population. We must stop just focusing on the 1.4 million and think about the 20% of the population, think about the 11 million as we move forward to NHS 80. We also need to focus on short-term, medium-term and long-term because the solutions to each of those workforce challenges are different. So, continuing with facts. Between 2012 and 2017, there was a growth in the NHS clinical workforce. That growth in whole-time equivalents, registered professionals, was 7.3%, or some 40,000 additional clinicians. But as you'll see from the slide behind me, there are peaks and troughs. GP numbers went down by 1.1%, 371 fewer GPs between 2012 and 2017. Emergency medicine consultants went up by almost 40% in that same period. We improved quality. The qualified nurse to occupied bed ratio in that period went from 1.86 to 2.02. In real terms, the NHS spent £3.7 billion more on pay in 2017 than we spent in 2012. But we have rota gaps, we have vacancies, we have staff working under pressure up and down our NHS. We saw a reduction in the amount of funding that was available for CPD and for workforce transformation. We see a lack of flexibility from employers. We're faced with an ageing population. We're faced with a growing population. In the 2012 to 2017 period, the population of England grew by 4.2%. When Patricia Hewitt was Secretary of State in 2005, she addressed the NHS conference then and said that the NHS interacts with 1 million people every 36 hours. In 2017, the NHS was interacting with 1 million people every 17 hours. In that 12-year period, the number of interactions, the workload, has more than doubled. It takes 12 years from somebody walking into medical school to becoming a consultant. So in the time in which our system has trained a consultant, the workload has doubled. And that's before we address complexity. So let me talk about supply for a moment. This is a graph that we produced in 2015 when we were asked to predict what the number of nurses coming into employment in the NHS would be by 2020. The green shaded area with the dotted lines on either side of it shows our predictions of what we thought the range of the number of nurses and midwives employed in the NHS would be. The blue line is the demand line from NHS employers in terms of them saying to us in 2015 what they actually wanted. The solid green line is what has actually happened. So, the number of nurses and midwives coming into NHS employment is within the range. Did we expect it to be right at the bottom of the range? No, we didn't. This isn't about training, because when we defined that range, we knew exactly how many nurses would be going into training. This isn't about retention at universities, because actually the retention on nurse training programs at universities was better than we anticipated in 2015. This isn't about people being recruited from training into employment. That has stayed as we predicted back in 2015. This is about retention of our existing workforce in NHS employment. We only have 3 ways of producing the future workforce. We can train more, we can recruit people who aren't currently working or have been trained elsewhere, and we can keep the ones we have. We have to address all 3 of those issues. This is not just about a new workforce. We also need to remember that by the time we get to NHS 80, 66%, 2/3 of the people who are currently working for the NHS will still be working for the NHS. If we want to transform how we provide healthcare, we need to focus on that 66% of people just as much as we need to focus on the new workforce coming through. So, what's happened to retention between 2012 and 2017? Excluding people leaving for retirement, the turnover in the NHS has gone from 7.3% per annum in 2012 to 8.7% per annum in 2017. If we had managed to keep retention of nurses in the NHS at the same level in 2017 that it was in 2012, 50% of the nursing vacancies in the NHS today would not exist. That is the scale that we are talking about. 50% of the nursing vacancies today would have been filled if we had managed to keep retention at 2012 levels. Over 5,000 people a year currently are leaving the NHS from nursing posts for reasons other than retirement compared to 2012. Now, NHSI and NHS employers and others are doing some fantastic work in this space, but they've also uncovered some really worrying statistics. So there is one trust where 40% of nurses that they recruited from university, from training programs, had left within the first 2 years. 40% of people leave within 2 years. Now, part of the problem, I know, is investment in CPD and workforce transformation. We said last year, we pledged last year, that we would do what we could to put more resource into that, and I am pleased to announce that this year's CPD budget will be 17% higher than last year's CPD budget. It is still not enough. We need to put serious investment into our current workforce to retain them and to give them the skills that they need. So training. We have increased training across all areas. 1,500 new medical student places have recently been announced as a result of a bidding exercise that we ran, and that includes 6 brand new medical schools in areas that were black spots when it came to the ability to try and recruit doctors. We know there's a correlation between where people train and where they are subsequently employed, and we wanted to try and address that by putting medical schools into those areas. So 1,500 extra medical students, that's a 25% increase in the number of doctors that we are going to be producing in this country. This slide is the end of round one recruitment into GP training programs. We're announcing today, 3,019 people have accepted posts on GP training programs so far in 2018. That means I can confidently say that we will hit the 3250 GP trainee numbers when we finish round 2 for the first time ever. That means that about 50% of all doctors who we train in this country are now choosing to go into general practice. We've seen similar results with psychiatry. We've had a 23% increase this year in the number of people being accepted onto training posts in psychiatry. But we also know from UCAS data that the number of nurses who were recruited onto nursing training programs this year at universities in England was down by 6%. We have got an additional 25% funding for clinical placements for nurse students, but we need to recruit people onto the courses in the first place. One of the questions that I want to address as well is that recruitment onto nurse training programs was down by 6%, but 17,000 young people who applied to universities for a nurse training place didn't get one. 17,000. Where are they? What are they doing? Why didn't they get one? Some of those people will have been entirely unsuitable. They may not have met the required academic competencies. They may not have the values and the behaviours that we want in the NHS, but we've turned away 17,000 people who want to train as nurses last year in this country. We've also seen the introduction of nursing associates, and the first cohort of nursing associates will graduate this December. We've seen a retention rate of 86% of that first 1,000, which is way beyond any of our expectations. And I do want to just pay tribute to some of the fantastic people that we've met who are training to become nursing associates. And just to give you a feel, I want to name one, Ian Costello, who is a trainee nursing associate in Hertfordshire, who has just been awarded the Dean's Award across the whole faculty for professionalism, employment, employability, and enterprise. One of our training nursing associates who's been working for a long time as a healthcare support worker in the NHS. Now, nursing associates is a career in itself, And by NHS 80, we expect there to be 45,000 nursing associates working in this country. We also expect 17,000 of those nursing associates to have gone on to train to be registered nurses by NHS 80. And it's not just on the clinical workforce that we're expanding numbers. We can also announce that we're increasing the size of the graduate management training scheme from the 150 that it was last year through 200 this year through to 500 by 2020. So as I've already said, training people is important. Recruiting them, once we've trained them, is also critically important. The blue line on that graph behind me is people on the GMC, doctors on the GMC register, so active doctors with a CCT in general practice. So people who have trained and are qualified to work as a GP in this country. The orange line is people in substantive employment in this country as a general practitioner. These are percentage changes year by year. The grey line is adding in to the orange line long-term locums. So the grey line is long-term locums plus people in substantive employment. Where's the gap? Where are the people between that blue line and that grey line? The vast majority of them are doing short-term locums in general practice in this country. Why? That isn't what we want. That isn't what our patients want. We want the continuity of care. We want these people in substantive employment. What can we do to attract these people into substantive employment? Just to give you another figure, we looked back at 5 years ago, people who gained their completion of training certificate in general practice 5 years ago. 60% of them are in substantive or long-term locum appointments in this country. Where are 40%? 40% of all the people who completed training 5 years ago as GPs are not working in substantive GP employment or as long-term locums. They are doing short-term locums, they are doing other things. Now, as every year goes by, beyond 5 years, that number goes up slightly. We have to address it. How do we train people? How do we keep people? It's not just one part of the equation. And by the way, let's add some money into this. To take somebody from the day they walk into medical school to the day they become qualified as a GP costs somewhere in the region of £500,000. So every person who we lose, the NHS has invested £500,000 in their training. So as we look towards NHS 80, what do we believe that the demand for staff is going to be? This is a graph that we pulled out of the draft workforce strategy that was based on some work looking at OBR figures in terms of what the likely growth in GDP was, the likely percentage investment in the NHS was going to be over that period of time. And we said that our best guess was that we would need 190,000 more members of staff in the NHS in 2027 than we had in 2017. If we do nothing other than what we were doing last year, we will produce 75,000 additional members of staff by 2027, giving us a gap of 115,000. We also believe that that range, that figure of 190,000, is at the lower end of what we're really going to need. We believe that the workforce needs to grow by between 3 and 5% per annum. We need to turn on all the taps. Our current growth projections will not deliver between 3 and 5% increase in the workforce every year for the next 10 years, with the exception of the overall medical workforce, where it will, but not in some areas such as general practice. We need to train, we need to recruit, we need to retain. We need to allow people to be able to work differently. We need to look at skill mix. I was visiting Derby Hospital recently, and I have to say I was absolutely blown away by the fantastic work that they're doing there with advanced clinical practitioners from a range of different backgrounds and the enormous impact that it's having on direct patient care. We need to think about the diversity of our workforce I was in a very powerful session yesterday with people from the Leadership Academy when the message couldn't have been put across clearer about some of the challenges that we still have with diversity in our workforce. And we in HE have got a big responsibility in this area. The NHS predominantly employs people who come out of UK universities. Therefore, the only choice of people you have to employ are the people who universities train in the first place. If we are not admitting people into training from diverse backgrounds who are representative of the population as a whole, we are not going to achieve a properly diverse workforce that we all want to see. We also need to focus on millennials. I talked about this last year. I made myself unpopular with some groups, but I stand by what I said then. The millennial generation want more flexibility, they want to work different hours, they want to change career more regularly. The NHS as an employer has to address that. We need to look forward. We need to plan from the workforce perspective for NHS 80. We have Eric Topol leading a report looking at the impact of technology on the delivery of healthcare in this country and what we need to do in changing the makeup of the workforce and training to address that. We have the Pearson report into the mental health of trainee and learners in this country and what more we can do to help and support people. We have a report led by Thomas Hughes Hallett into volunteering in the NHS, what more we can do to embrace volunteering and to make sure we're properly educating and training our volunteers. We have our Patient Advisory Forum within HE, looking at education and training for carers, looking at education and training for self-carers. Interim reports from all these areas will be produced in the next 2 to 3 weeks, with substantive reports for the end of the year. So, as we celebrate NHS 70, we must recognise the remarkable contribution that our entire workforce makes to the NHS, including the Windrush generation and including the legacy of the children of the Windrush generation. Today, as I said when we started, we must also recognise the skill, bravery, flexibility and compassion of those NHS staff who worked and people caught up in the Grenfell tragedy. I've just passed 35 years working for the NHS. I'm still proud to be an NHS employee. Yes, quite rightly, we focus on what's wrong. We focus on what we could do better. But you know what? Day in, day out, people in this room, people up and down the country working for the NHS make a fantastic difference to people's lives. We want to see an NHS workforce that is stronger and more robust in numbers. And we want to make sure that as we produce the final strategy later this year, that we have a clear set of actions to deliver that. Thank you.
Thanks very much indeed, Ian. There'll be people appearing with microphones. If you put up your hand to ask a question, we'll get the paddles going. So, really simple question. Are you optimistic in terms of us being able to get the staff we need to achieve what we want to achieve over, assuming we get some funding to help us do this, over this period? Is this crackable?
There's no shortage of people who want to come and work in healthcare. We see very, very large numbers of people expressing an interest. We have got to focus on the retention issue, though. We cannot simply keep producing more and more and more people when we have people who, for whatever reasons, are dissatisfied with the employment offer that they are getting. They're dissatisfied with the education and training that they're getting post-qualification, and therefore they are leaving. We have to address both parts of this. It's like a bath with water coming in from a tap at one end and out a plug at the other end. We need to make sure that we reduce the outflow of water.
And in my remarks, I did say plug is as important as tap. Number one, please.
Hello, Debbie Frost from Barnet CCG. I'm a GP and I'm the chair of the CCG. In Barnet and Enfield, we've had a very good programme for nurse trainees coming into general practice. My practice has taken them over the last couple of years, but this year I'm told that instead of having them as with GP trainees fully funded into the practices are going to have to pay. And I just think that my fellow GPs are just not going to take those nurses who want to come into a more flexible job. And I just think there's often unintended consequences with funding. And I just thought, is there a way that we can flag these kind of things up? Because when we're on the ground, we know what's happening.
Yes, please. I'm not aware that we have made any changes in terms of how we are funding the placement of nurses for education and training. We absolutely want people to be able to rotate, not just through primary care, but also through social care, because it's an invaluable part of their training. So, I mean, please catch myself. In fact, my director of nursing sat over there, so I will point her in your direction afterwards, because that's not something that we're aware of. And if things are happening locally, please raise it with the local director, regional director of HE, or indeed come through to myself, because we need to make sure that we aren't making life harder when we're actually trying to make life better.
Okay. Number 2, please.
Hi, Phil Confed18, Cornwall Partnership. Really, it's how can HE help? We know the retention issue, and we train small numbers through the Open University ourselves, and that's our staff, and they retain, and they work really well because they know what they're coming into. But when we try to talk to local universities about increasing training, provide it in a local, accessible way within Cornwall and not sort of 50 miles away, they're really intransigent about it, and they won't train learning disability nurses, and they won't train district nurses. What leverage do you have that you can give us to help the universities deliver for us rather than their own agenda?
Yeah, I think that's a very good question. There are a number of areas in which, viewed from a purely commercial perspective on behalf of a university, they may not be interested in continuing to train individuals who are absolutely vital to the future of the NHS. If I could use podiatry as an example, where we have a number of universities talking about whether or not podiatry courses are viable into the future, we absolutely need podiatrists. So what we're doing is we're working with what was HEFCE, now the Office for Students, to actually look at some of the levers that they have, both stick and carrot, over universities in terms of incentivising particular courses or subsidising particular courses where the tuition fees may not cover the full costs. We're also very keen to work with a number of universities who are increasingly expressing interests in running courses on an outreach basis. So actually developing more university bases within NHS employers. So that wouldn't then need necessarily to be your local university. It could be any university anywhere in the country that was interested in doing a distance learning program for nursing, including mental health, including LD, for podiatry, for whatever it may be. And I think that is going to be part of the solution, because we have some universities who, as you say, are losing interest in training people in health. We have others who are actually gaining huge amounts of interest, and we need to tap those into your local areas.
Okay. Number 4.
Hi, it's Dr. Subodh Dave, Associate Dean, Royal College Psychiatrist with a remit for supporting trainees, and particularly international medical graduates. My question is about, we know that 40%, almost 40% of the workforce in some parts, especially primary care, psychiatry, is made up of international medical graduates, and we have a large number of other healthcare professionals, including nurses, who come in to work from abroad. I find that support for them very early on is almost non-existent. At the local level, I think deaneries don't even know what proportion of their trainees are made up of local graduates and how many are international graduates. So it's practically impossible for them to tailor adaptation for these international workforce to work in the NHS, which obviously has an impact on not just these trainees' morale. We know that they have problems later on in the exams, but also affects patient care and safety. It's an issue, I think, which has been left for colleges to address, and I really would like to see HE come up with a response. Thank you.
Thank you. Wendy Reid, who's our medical director, has been doing some work in this area with Sean McLeod. And if I can broaden your question slightly to also include another really, really critically important group of the workforce who we don't pay enough attention to from our perspective, and that's both the trust grade doctors and the SAS doctors, who day in, day out are delivering so much care in the NHS, yet we're not giving them the same education and training development opportunity. We're not looking after them under the deanery footprint in the same way. So our ambition is to find a way of bringing all doctors, whether they're in a training programme or whether they're employed by a trust or indeed whether they're employed by a university in an academic post, bring them all somehow under the umbrella of the dean, not so that we're controlling what they do or anything like that, but simply so we're aware of people. And I suppose in the same way as we've been having a conversation about talent management for leaders and managers in the NHS, to actually allow us to track our people and invest in the talent management of everybody. Now, with regard to international graduates coming into training places in this country, they form a critical part of our workforce. They always have done, and they will continue to do so. We are working through the international team in HE to actually try and better track people. We have some coordinated programs around Earn, Learn and Return, who are specifically for people to come to this country who intend to return at the end of it, having trained and developed here. We need to mirror that with something similar for people who want to come and train here and stay here at the end of it and make this their home.
Okay, now we're running short of time. I'm going to just ask 1 and 3, if you can make questions really briefly short, and Ian will answer very briefly as well. 1 and 3, and then we're...
Kathy Williams from ODAS. I'd like to know a little bit more about the priority that's going to be given to the 1.5 million people who work in social care with a 27% turnover rate, and real concerns and a sense of shame that this is a national living wage sector. And of course it links to your points earlier about funding, and we really welcome the recognition with Confed that this is a bigger nut to crack.
Thank you very much. And 3.
Hi there, Chris Woodall from the Royal College of Anaesthetists. We talk about the ageing population quite a bit, but what we don't talk about is the cliff edge of retirement in terms of the consultant population in our clinical workforce. And I know that among anaesthetists, there's a number who approach retirement and are kind of waved off into the horizon, whereas they would appreciate a role where they could stay within the clinical workforce, providing mentoring and perioperative care in a kind of a non-traditional way. And what can HE do to help facilitate that kind of a evolving role?
Ian, I think...
Okay, 2 great questions, both of which are difficult to give a short answer to, so please do catch me after the session. Social care, we cannot continue to look at the silos that we work in the moment. I've said a couple of times over the last few days that our nursing associate programme has made problems worse in social care, not better. And there's one trust that's one of our big pilot sites for nursing associates who've fully recruited to the programme. People are having a brilliant experience. They've taken from their own healthcare support workers. They've then recruited new healthcare support workers in, and guess where they've recruited them from? Social care. So we've passed the vacancy problem onto social care. So as we develop a strategy very much around careers, not jobs, we have to do this hand in hand with social care, and we have to work as closely together as we possibly can. On the issue of retirement cliff edges, the data doesn't show a cliff edge. So if you look at the number of people who retire year on year, and if you look at the predictions for the next few years, the line is up a little bit, but we're talking about 0.2%, nothing like the numbers that we're actually seeing of people leaving for other reasons. However, if we can keep people for longer than they intended to work, we will have a further impact on the size of our workforce. I've said previously that we need to address 3 phases in the working lives of people, professionals in particular, in our NHS. There's the phase when we first appoint people, when we need to give them more mentoring, more support, more advice, more input than we ever have done before. There's the big bit in the middle when they're delivering the job, they're developing research interests, training interests, etc. And then there's the bit that we don't focus enough on, which is the bit at the end. How do we make sure that we aren't asking people in their late 50s or early 60s to work night shifts? How do we make sure we're not putting people onto on-call rotas that mean they have to get out of bed at 3 o'clock in the morning? What you can do when you're 30, you can't do when you're 60. And I think how we treat people and look after people is a critically important part of that.
Okay, Ian, thank you first of all for a really clear exposition and address, and also for answering questions so frankly. Thanks very much indeed.
Thank you.
As John Cleese would say now, for something completely different, we thought we would have a formal debate on the vexed issue of regulation and inspection, and who better to preside over the proceedings than my former colleague, BBC Today presenter and mastermind host, John Humphrys.
Over there. Thank you, Neil. I'm looking for the lectern. Where is it? Oh, it's there. Good morning. Afternoon. No, it is still morning. And thank you for mentioning Mastermind. I always appreciate that because I've been doing Today programme for so long, and you know, all those years of interviewing politicians, and now to be doing Mastermind and asking people questions, knowing that they want to answer them. I have to tell you, we do have some slightly bizarre answers, I have to say. Just while you're settling down, let me just test you with this one. I asked somebody on Celebrity Mastermind what breakfast cereal they associated with prison. Yes, and he said Cheerios, which actually rather wonderful, isn't it? I wasn't quite sure whether he was making a comment on the government's penal system or whether he was just bloody thick. I think it was probably the latter. It was a politician. I'll tell you the name later. There'll be no trick questions today, no silly questions today either, I imagine, because this is a hugely, hugely important debate. I'm tempted to say that Theresa May might possibly call it a meaningful vote. Whether it has that degree of importance is another matter. I suspect for many, many people in this country it's even more important than that. Whether, of course, at the end of it you will have a Hexit rather than Brexit, we shall see. And whether it means you'll be getting another 350 million quid a week for your hospitals, well, we'll see that as well. But it's an important debate. There is no question about it. Regulation and inspection, do they do more harm than good? Let me just tell you roughly how it's going to go. The first thing to say, and you may have heard an announcement a moment ago, we are at 12 o'clock going to have a minute's silence, if you just stand up for a minute to remember the dead of Grenfell. We will be doing that at 12 o'clock, so forgive me if I interrupt the proceedings at 12 o'clock. And the idea is that I'm going to ask you to vote, then we're going to hear a 5-minute plea from either side, and our two speakers I will introduce in just a moment, and that's it. But first of all, let's show you what there it is, regulation and inspection, do they do more harm than good? So you already voted, have you? Oh, all right. No, you're still voting, even as we speak. Excellent. Ooh. Are you changing your minds, or are you just pressing the wrong buttons, or what? What? Right. Oh, I didn't know my words were coming up there. That's horrible, isn't it? Look, don't look at me. It's not my fault. I have no idea what's going on. Can I just... Oh, I see. It is, it's swinging a lot, isn't it? How many of you are there? Yeah. Gosh, how exciting. Do we know? Can anybody tell me how many people there are in the audience? Roughly? I just wonder whether we're going to be through by lunchtime, that's all. No. I don't know whether this means you're making up your minds and taking time to think about it, or whether you're all trying to vote at the same time and the equipment is slightly slower than you are, as it were. But either way, it's jolly close and hugely exciting, isn't it? Well, all right, exciting is maybe, yeah, all right. No, I'll settle for exciting. I think it's exciting. No, still going. And it's getting even, yeah? Right, I think, no, oh gosh, no. I'll say nothing, perhaps it's slowing it down. Just settle for that? All right, well, we're going to assume, look, we're going to assume that it's around 54 to 46% as we speak. And we're going to hear arguments for and against that proposition from Jennifer Dixon, Dr. Jennifer Dixon, who is Chief Executive of the Health Foundation. You know all about the Health Foundation, of course. Peter Homa CBE, he chairs the NHS Leadership Academy now, former, and this is the important bit for the purpose of this discussion, former Chief Executive of the Healthcare Commission. So would you welcome them, please? And we will hear from each of them, starting with Jennifer, for 5 minutes, and that is a no-nonsense 5 minutes. If they go over, I'm afraid I shall have to chop them off. And then at the end of that, we shall have a wee bit of a discussion, and I hope that you will join in. Jennifer, kick it off, if you would.
Thank you very much. Oh, this is nice, isn't it? Good morning, everybody. So regulation and inspection causes more harm than good. So let's just have a couple of things out of the way first, because I'm kind of an academic. What is regulation? Well, set of rules that you're required to do by somebody other than yourself, I think is probably a good definition. So regulation is not just CQC, of course, it's also other people who require you to do things, NHS England, NHS Improvement, professional regulatory bodies, colleges, health and safety, even locally CCG, CSU, and so on and so forth. So a lot of bodies that fall under the definition of regulation of providers, you might say. And then the other thing I think is probably worth clearing up is what do we mean by good here, if it's causing more harm than good? Well, there are a number of good things that regulations do. They set out standards and somebody checks against them. They try to protect against risks now and in the future, risks of harm. They can also be good. The good is also to improve things, to make things better. Good is also that they increase accountability to government and taxpayers in our case. And they can also help to provide information for choice. So I think that's some of the dimensions of good. So let's have a look at the case. So I think the first thing to say is that nobody, unless you're an extremist, I think, argues that that all regulation is bad, that we shouldn't have any regulation. The question really on the table is the volume and the type of regulation. And have we got to a point at the moment where we've reached a tipping point where the volume and type is causing more harm than good? So let's have a look at some of the arguments to support that. And I am going to focus some comments really on quality regulation more than anything else. So I think there are 4 big reasons to support this case. The first reason you can argue, the total burden of regulation. The financial costs are high on those being done too. The time burden is high and it distracts from care. So that's a big opportunity cost. And the duplication and frustration as a result of that is also high. Many of you will have extreme examples of this in your own world. So I think that's the first main argument, the total burden and its opportunity costs. The second argument is that too much external regulation reduces and infantilizes those being regulated, and it can reduce self-scrutiny. So you think, well, other people are doing it, I don't need to devote so much effort. So the locus of control is outside of you, which is really where you need to try to encourage the system to become much more self-regulatory right at the coalface. And what's more than that, depending on the style of regulation, it can induce defensive behavior of those being regulated. So I think that's the second big reason why regulation can cause more harm than good. I think the third reason, and to support the argument, is that there is some evidence to show that regulation has resulted in good on those dimensions I mentioned, particularly improvements against standards. But that evidence is not that strong. So, for example, if you look at the CQC's own provider survey, 80% of those say that when they've been regulated and inspected, that it encourages improvement. That's what they say in a survey that has a 21% response rate, by the way. And of those who've been rated, 136 non-specialist trusts, those who were re-inspected because of a weakness in a particular area, 54% on re-inspection had no change in that rating. 35% improved, but 11% actually had a lower rating on re-inspection. And that also translates to core services as well. When you think of core services rather than whole trust, the figures are more or less the same. 52% no change after re-inspection. So I think that's the third argument for the motion. And also, not only has improvement been sort of weak, evidence of, but also there isn't that much evidence that regulation, as is at the moment, has actually reduced risks, particularly future risks or perceived risks of the future. And I think that's quite a strong statement to make, because one of the reasons why quality regulation, as we know, came in was actually to reduce the risks, to show a smoke signal, and therefore to reduce the risks of catastrophic, scandalous care, which we recognise after mid-staff's experience. And furthermore, 55% of trusts, when asked, say that inspection did not reveal new problems. So inspection isn't uncovering new issues against whether there are risks or areas for improvement. So that's the third reason. I've got 35 seconds left. And the fourth reason is the validity of the approach of regulation is also quite questionable. Can it really measure quality? Can it really measure the risks that you need to?
Jennifer, I'm afraid we'll have to leave that hanging in the air. If you can answer your own question in 1 second, that's all right.
Okay, so I will sum up in a minute, but I hope I've put the case on 4 major arguments why you should support this motion. Thank you.
Thank you very much. And you'll get a chance to elaborate in the Q&A, but they'll kill me if I allow you to go over time. And with that stricture, Peter, off you go.
Thank you. I come to this having been an NHS Chief Executive prior to comprehensive NHS inspections. I've been responsible with others for setting up an inspectorate, as John mentioned, the Commission for Health Improvement, and I've been both an inspector and inspected. And I'm very clear that the most powerful force and drive for improving patient and service user care comes from the passion, expertise, dedication, determination of staff, patients, and their loved ones. And I'm very respectful that public and private healthcare and social care inspection is complex, challenging, and requires exquisitely careful judgments. We know that citizens hold the state accountable for their care across the arc of their lives, from the premature neonate to the frail 96-year-old in a care home with vascular dementia and abandoned by their family. Independent inspection, and I'm referring particularly in this submission to CQC, provides an important mechanism for fulfilling that obligation. And the best way to assess the quality of care is a combination of quantitative, qualitative evidence and analyses. The lived experience of patients, their loved ones and staff are revelatory. The CQC publishes, we know, independent inspection reports on every English healthcare provider and social care and system. And their teams importantly include practicing NHS staff and patients. In their work, they talk to leaders, frontline staff, patients, service users to reach informed judgments in terms of the quality of care. And these help identify for providers what's working well, what needs to be improved. And the 70th anniversary year, we celebrate the NHS as a much-loved, valued public service. And in my opinion, it should be a leader in openness, transparency, and accountability. And amongst other things, CQC reports are important instruments of public accountability. Experience tells me that we as providers get out of inspection what we put in. If we regard the inspection as part of an overall process program for improvement that will enrich our understanding of what we're doing well, what we can improve, then the likely outcome is an acceleration of the rate of progress. If we enter the exercise defensively, only partially sharing contemporary challenges and risks, then it's much more likely to be a much less valuable outcome. And if I may, an uplifting example is West Suffolk FT, under the inspirational leadership of Steve Dunn, Chief Executive, and Chair Sheila Childerhouse. They set the goal for their services to be outstanding, including but not exclusive, including as judged by the CQC, and congratulations to them and all their staff, they achieved it. And it's no coincidence, ladies and gentlemen, that West Suffolk also achieved simultaneously the highest percentage in the National Staff Survey of staff recommending their organisation as a place to work and indeed to receive care. And I'd like now to acknowledge the health and social care value-centred leaders, including Stephen and Sheila, and indeed many others who are in this room, for making the world a better place. I've had the privilege of working with many over my career, and I've met even more during the time as chair of the National Health Service Leadership Academy. Now, I know we've got our own poll, and Jennifer's already made reference to one, the CQC 2018 Annual Provider Survey, which in fact, notwithstanding the response rate, captured 7,500 respondents, 80% of whom agreed that CQC encourages health and social services to improve. I'm not in any way pretending that the inspection methodology is perfect, but like all processes, it's in need of continuous improvement and refinement, and that's what it needs, not abandonment. And CQC has, in short, established a benchmark with all of its imperfections of care quality across the country. As far as I'm aware, it is the first of its kind across the world, and there's considerable international traffic to better understand how to improve the validity and reliability of inspection methodologies. Also important to note, and the comment about the cost of CQC is in the order of £223 million per annum, not an insubstantial sum, approximately 0.16% of the total spend on health and social care. And I'm very clear that we need to make sure that inspection needs to be thoughtfully calibrated, and the weight of required assurance should be in inverse proportion to the evidence of a provider's quality improvement. So the foregoing, ladies and gentlemen, is why I believe inspections, with all their imperfections, are a positive force for those we serve, the public, patients, their loved ones, and staff. Thank you.
Thank you very much, Peter. Obviously, Jennifer acknowledged that there has to be regulation. She doesn't question that for a moment, but she made four really rather important points, didn't she? It costs an awful lot of money. It is a huge burden on those who have to administer it. It reduces scrutiny. That is to say, the assumption is that somebody else, beyond the ward, beyond the surgery, whatever it is going to look after what's going on and keep an eye on what's going on. And there's no evidence that they do. There's no evidence actually to show that it works. 54% of re-inspections resulted in no change, and it hasn't reduced the risk of catastrophic scandalous care. That's a pretty damning list, isn't it?
It is a thesis, John, but what we haven't...
You may come back on that, by the way, Jennifer.
What we haven't acknowledged is there's no research into the counterfactual. We haven't done any research into what would have happened if we didn't have inspection. Now, I think it's very important...
Sorry, before you leave that point, surely it has to prove its worth, doesn't it?
And I think there's sufficient evidence...
In which case the counterfactual is a kind of secondary.
And I think there's sufficient evidence that it has. If we look at the product of the Francis report, and I was involved in one of the aspects of Sir Robert's work, the impact of the Francis report in helping to fashion the methodology, the inspection methodology of CQC is very important, and that has led to a very significant enhancement in the amount of quality time that boards give to quality. Previously, there was enormous asymmetry. Most board time was devoted to money, not quality. And the controlling mind is the most important dimension in quality improvement, i.e. the board of a hospital or health services provider. It is not, and we should never rely on external inspection as being the mechanism that is the primary driver for quality improvement. In terms of cost, I believe that 0.16 is a modest share of the overall spend in terms of inspection.
Modest share of a very large amount of money.
Entirely fair, and I entirely accept there is a wholesale redefinition in terms of how inspection is conducted. There are too many inspectorates. They need to be rationalised. There need to be fewer requirements in terms of information on providers. And as I say, that's an argument for refinement, not abandonment of the inspection.
You scared off whistleblowers?
Pardon?
Are you scaring off whistleblowers?
I think whistleblowing is an enormously important resource.
Everybody says that, but it's just lip service, isn't it?
Well, I've been working in a trust recently where, until recently, whistleblowers felt insecure to blow the whistle inside the organisation and therefore went to CQC. And what that's done is encourage the board of that institution to give much deeper thought as how to ensure that staff feel safe to blow the whistle and make sure that they feel that there's a deep concern at board level and elsewhere within the organisation to make improvements when staff have concerns.
All right, Jennifer, I listed probably not terribly accurately, but nonetheless, your 4 main points, or seem to be your 4 main points. Are you suggesting at the end of that, your thesis, that we need to get rid of this whole thing and start all over again, or that obviously you've acknowledged there must be regulation, you'd have to be an idiot not to, of course, there must be regulation. Is there an easier, simpler, more effective, less time-consuming, for want of a better word, way of doing it?
Well, so I confess I was on the board of the Healthcare Commission, the Audit Commission, which is for regulative local government, and also the CQC. So I absolutely believe in regulation. I think it's a force for good, most definitely. And I think the thesis, I guess, is not that it causes harm necessarily, but is the burden now too great that it is actually causing risks? That's what I think we as an...
Adding to the risk.
Adding to the risk. So if you think of a U-shaped sort of graph with a little bit of regulation at the bottom causing a fantastic reduction in risks, and then there's a kind of sort of plateauing, and then with too much regulation it can actually increase the risks because of the amount of time, effort, and indeed money. And
you're saying we are
well,
on the upward path?
I think the answer is that truly nobody knows. Nobody knows where we are. So what we then have to do is constantly reflect and assess. Confederation did a nice piece of work on the burden of bureaucracy, actually, more generally, in 2013. And maybe it's time to do that again. Certainly, maybe every 5 years to assess for providers whether this burden is too much. So it's the burden, but it's also the validity. How good is the system that we have? How good is it at assessing and spotting not just risks now, but risks possibly in the future?
So take another look at it, is what you're saying.
Take another look at it and iterate and evolve, not throw it all away, because that's our traditional way in the NHS, isn't it? To scrap institutions. You know, Peter was only in charge of CHI for 4 years, wasn't it? Then I went into the Healthcare Commission, and then so we don't want that. But what we do want is intelligent evolution, and that requires increasing scrutiny to make sure we're not on this.
Who guards the guardians, though?
Who guard the guardians? Well, maybe we have to do it ourselves. You know, maybe
we being?
Maybe, well, the membership of this room, the Confederation, or others who take a lead in saying we have to constantly assess this.
And how do you get that sense of what everybody feels? I mean, apart from a debate like this, of course.
Well, I think you probably have to do some more careful work on the costs and the risks and the opportunity costs of the current
I'm going to hurry you here
got.
because we have our little standing up bit coming up. Peter, just a quick thought on that, on what Jennifer's just said. Should we take another look at it?
We furiously agree that there needs to be a wholesale redefinition of inspection to rationalise the burden on providers and others. I think one way of helping to make sure that there's a real sense of reality in terms of the inspection regime is to encourage the audience to encourage their doctors, nurses, other staff to become members of the CQC inspection team, so they can bring that lived experience to make sure there's a reality.
You're not just going to add more bureaucracy on then?
On the contrary, what happens, and I've benefited in Nottingham from this myself, John, is when one has colleagues from one's own organisation go and visit others, you always learn lots of valuable stuff and you can bring it back to the organisation.
All right.
So I think that needs, the other aspect, which I think is a very important additional facility for inspection, is to enhance and improve the predictive ability of inspections so that one can anticipate problems before they occur.
All right, we'll pause there if we may, and could I ask you, ladies and gentlemen, just to stand up in recognition for a moment of the Grenfell victims. Thank you very much. And let's open it up to the floor now. Questions, please. You know the routine, so I won't bore you with that. There we are. There's number 1. Go ahead, if you would.
Thank you very much for interesting presentations on both sides. Just wondering how, with the regulation you've both said is important, we cannot stifle innovation. We've talked a lot throughout the last 2 days about how important innovation is, and yet our traditional way of regulating and inspecting sometimes sees that as something to be worried about rather than celebrated. And some of the best examples we've seen of service change have happened when, quite honestly, regulators aren't looking or inspectors aren't looking. And then everyone goes, oh, that was brilliant, other people can do it. So how can we marry those two things?
Yeah. What do you think, Peter?
It's a really important question, and I'm going to add a bit of advertisement for Jennifer. There is a magisterial study, and Jennifer is one of 3 authors with Don Berwick and Chris Ham on quality improvement in the NHS. And what that describes, and you can speak more eloquently than I can, Jennifer, what that describes is the answer to your question in principle, and that is that NHS organisations and systems have to have a long-term absolute commitment to quality improvement. It needs to be resourced. It needs to draw on the best experience around the world. There are many examples. Marion Griffiths in Sussex provides an inspirational example. The Sheffield Trust, that the foundation is involved in, provides another. And that means that those areas that are open and ready for innovation can thrive at the same time as making sure standardization occurs. But otherwise, there's a real risk, exactly as your question implies, that if we exclusively focus on the inspection model, we will deny the oxygen that improvement in other areas requires.
I imagine you'd agree with that, Jennifer.
Well, yes, I think the regulators themselves need to become more agile, and they kind of are trying. You know, obviously, CQC is looking at new models of care, for example, but I think the big wave here is technological change. And if you think what's hitting us, what's about to hit us, I don't think we are nearly agile enough. 350,000 apps to try and improve healthcare, of which 40 are on the NHS Choices website, I understand. You know, that's a huge bottleneck. So I know NICE is beginning to look at, for example, how to more be more agile in assessment. But this is going to require a whole different speed of change by the regulators than we've ever seen before.
Thank you. And number 4, if we could keep the answer questions as short as possible, it'd be great. Number 4.
Thank you, Nick Hume, Chief Executive of Ipswich and Colchester Hospitals. Just a question really to both of the. There's a lot of anecdote and allegation in a lot of the reports that we see, you know, staff thought, and you find out it was one member of staff. Do we need to be more scientific rather than relying on anecdote and allegation?
Good point. Jennifer? More scientific, too much anecdote.
From staff? So I didn't...
That's what you meant, presumably, just...
In the inspection?
In the reports, you often see staff felt, and actually
it's too vague.
Back, and it's one member of the staff that felt.
Yeah, you want to try and nail that down a bit, is what you're saying, yeah?
This is very difficult. So it kind of... It's not possible to get a full... If you think about something as complex as a hospital, how on earth do you get an assessment? Data can't do it. Data just aren't everywhere. They're not full enough. You have to go and smell the coffee. You have to go and see. Once you go and see and smell the coffee, then you're into a lot of anecdote, intuition, as well as the quantitative stuff that you're actually looking at and the standards and so on. So this is one of the criticisms of any inspection regime, is how much weight do you put on that kind of thing? And this has been some of the criticism of the CQC's.
Isn't there some kind of formula there? Well, maybe a consultant surgeon's view is more valued than, this is dangerous territory.
No, or not.
Well, quite.
Exactly. There's no sausage machine. You can put all this stuff in, crank the handle in an algorithm and get the kind of homogenized result out at the end. It is not possible. If you think about someone inspecting, it's all happenstance, isn't it? A lot of it is, apart from the stuff they have to look at, do you have this policy in place? Is the fridge the right temperature? You know, does care look as if it's caring?
Are you proactive enough, or are they proactive enough in searching out contrary views?
Yes, I mean, there's a huge effort that's gone, this is where we differ from regulation in other countries, by the way. There's a huge pre-inspection analysis, not just of data, but also taking the temperature with a whole range of staff groups. It's really, people bend over backwards, and actually on the inspection teams are experts by experience as well, just as Peter said. So I don't know how it can get less anecdotal, but I don't think we should drive out the anecdote either.
Peter?
I think it's a very fair criticism, Nick. A triangulation of evidence is important with all the imperfections of trying to do that. A real challenge for inspectorates, and it was a challenge to the Commission of Health Improvement, to use the jargon in the trade, inter-rater reliability. If a different team goes into the same organisation, will they come up with the same results? And I think, in fairness, there's more work to be done on that. And there's some really great examples of Canadian health systems that do some very good work of enhancing inter-rater reliability. And maybe there's something we should learn on that.
All right, thank you. Number 2.
Hi, so my question was about regulations and inspections, and specifically whether you thought the measures are the ones that are the most important to the service users themselves. I mean, I have my own opinion, but it would just be interesting to have your sort of insight.
Give us yours in 20 seconds.
I'm not sure it is, and I don't think that's through any deliberate action, but I do feel that sometimes we have a relationship with patients where we assume we know what they want without actually asking them a question.
What a good point. Go on, Peter.
I think it's a really good point. And there's a very good piece of work recently published on 5 years post-Francis. And what the research demonstrates is that boards are much better sighted of the requirements of the regulator than they are patients. So I think there's a huge amount of work for regulators and indeed for us working with the NHS to better understand what's really important to patients. And what comes across very often in surveys is the humanity of care, is the important interaction of a member of staff and a patient and their loved ones, which receive relatively little attention except in the caring domain, and that's perhaps not as fulsome as it might be in this regard. So I think your point's a very good one. And again, it's an area for further improvement.
Jennifer.
Yeah, I mean, could be better, but not forgetting that the CQC, in its development of safe, caring, responsive, effective and well-led domains, that was also co-designed with patients too. So absolutely could be more responsive, agreed. And again, this is an iterative development.
Another question? Good heavens, we have drained you of questions. And actually, oh no, there is somebody gesturing frantically. There we go. Yes.
Hi, Sue Marshall, Chief Nurse at Sussex Community FT. How and when are we going to be able to inspect across place-based systems?
Everybody else would understand that, but across, for my benefit.
So across organisations, as we're working as part of the STP, how are we going to manage that regulatory process across the system?
As far as I understand, CQC already have some piloting of this going on at the moment. Clearly, you can't just rush to it because it's only just developing, but it's definitely in their sights and it's certainly in their forward strategy. So that's, but again, going back to the point, what is regulation? There are other regulators as well. So there's some coordination that needs to be done, not just with the NHS ENI, but with the CQC and with others locally.
And I suppose the other thing is how do you manage then the overall rating?
Yeah, that's to be determined. But it's useful. I mean, if you think about general practice, one of the issues with general practice that the GPs will say is that our contribution to care is part of a pathway. You can't just observe it in of itself as a hermetically sealed, and we've never been able to answer that with regulation. So the kinds of things we look at with general practice are kind of processy type of things, not really outcomes related things, which now can be at least begun to be addressed more in a place-based approach.
All right, let me just, you're happy with that, aren't you? Let me just finish because we are almost out of time. We've got a couple of minutes left, that's all. Each of you, in 30 seconds, as we say on the Today programme too often, if you could wave a magic wand and either add a bit of regulation on, another rule or a change to the present system, or take something away from the system that we have now, what would it be? Peter, as the champion of the system as it stands, I'm assuming you have to say it's jolly good and I wouldn't touch it.
That isn't what I said in my remarks, John. I think there is a major piece of work to press the pause button, to deconstruct the present inspectorial regime across all of its facets in the way that Jennifer, and then to reconstruct it in a way that's much more respectful of people's time.
Yes, I'd like to see more joined up regulation with different sectors and a focus on clinical outcomes, which is much more, sorry, that sounds rather technical, but which is looking at the outcomes of care across a range of providers, because I don't think we have a sufficient look at that at the moment.
Have you ever asked the general public in a sort of survey or whatever? I don't quite know what the question would be, admittedly, whether they think you guys, all of you people here, are being regulated enough or too much?
The public? I'm not sure the public would the public understand what regulation is?
Well, that
is the
quite,
question.
And that's for another debate, isn't it?
When I last looked,
exactly.
4% of the public use the, I mean, there's over 1 million downloads of the reports, that's for sure, but in terms of regular looking at the CQC's website, it's something like 4 or 5%. It's actually quite low. When I last looked, that might have changed. So I think the public just expects, as in the airline industry, that there is safety, that the services are going to receive as good quality. So asking them more detailed questions, I mean, that's I don't know.
In the end, they're concerned about whether their mum gets better or not.
Quite. I think for care homes, it's different. There's a much higher use as people make the decision of use of care home.
And there's a whole other debate to be had around that, isn't there, conflating the two. Anyway, let's see now, having heard some of the arguments, let's see whether you have changed your minds as to whether there is too much, whether it's a good thing or a bad thing, and do more harm than good. Here it is. Let's have a look at... it was, if you remember, it was, I think, because it sort of was moving quite a lot, but it was roughly 56-44, wasn't it, before the debate began. So, and slightly difficult because some people have had to leave to go to another session. So, but nonetheless, maybe the proportion will have been unchanged. That's to say, those pros and cons will have been unchanged. Let's just give it a moment to settle down.
Peter's done a great job. and I'd vote for that too.
Yes. Well, that looks as if it's pretty much stabilized there, and it rather looks as though opinion has shifted. Yeah. Well, what do you think? Shall we take that? I'm looking at Neil to see whether we should take that as the and there has been a shift in opinion as a result.
And it cost me a fortune to engineer that, ladies and
I
gentlemen.
was going to say, all those people who left, presumably you paid them to leave. Neil, let's just have a very quick comment from you before we close the session on what, because this will be reported tomorrow, I dare say, and it would have been a slightly bigger story, as it were, if there'd been a massive vote saying that it's doing more harm than good. However, here we have, well, not exactly the opposite, but it's not quite what we'd expect.
Well,
so what do you think?
Well, I think, first of all, our two speakers almost swapped sides during the course of the debate. So that certainly probably caused some confusion amongst everybody. But the debate did what the debate is meant to do, which is shift opinion. And that's a pretty dramatic move towards, in a way, the case for regulation and inspection. And it's very interesting, if we'd had that debate some years ago when CQC was in its earlier form, I guess the figures would have been very, very different, and they would have been much more hostile to the notion of regulation. So to that extent, I think that's to the credit. I think it did, though, both sides again highlighted there are still issues around triangulating evidence, how the inspected themselves react to inspection, and in some of it is about what you make of it yourself. I think the burden still needs to be justified, the cost still needs to be justified, and understanding more about what patients actually value and rate. So I think it's Jennifer used the word, I think it's an evolving picture, but it is acting as a valve, it is concentrating minds, and there is some evidence of impact. So I think on balance, the right answer, of course, was from the audience.
Nicely stage managed. I mean, nicely. Thank you very much for doing that. Thank you for being here, and thank you very much to Jennifer and Peter for their contributions.
Thank you very much.
And I think you have lunch now, or something. I'm not sure. I guess that's that.